Hey, Mohammed, how are you? Just give it a few moments.
The people used to want to do.
Okay, let's see here. Why don't we get going then? Okay. Um, so this is a 12-year-old who had syncope 2 weeks ago. And the question is, what do we think about the CCG? What should the workup be of this patient, etc.? So why don't we ask Mohammed what he thinks?
Good morning, Dr. Pass.
Good morning.
So looking at this EKG, I think the rate is about it's, 100. It's a little over 50, I guess. Um, and
I think it's closer to 60, but okay. Yep.
yeah, I'm sorry, I'm too good with the math. The PR is prolonged. Looking just at the P waves. Um, so I think it's sinus rhythm, but the PR is prolonged.
Mm-hmm.
So I'm guessing.
How would you describe this other than that the PR is prolonged? Is there a term for people whose
Yeah,
PR?
like first degree heart fraud.
Okay. So what do you want to do with this patient? They came in to see you because of a syncopal episode, and now you're seeing the patient in the office for the first time.
Um, so just one time syncope.
I'm sorry?
I think to start with, I'll get a halter study or a zero patch on them.
Okay. What are you looking for on that? I
If
don't,
if if it's
I agree
if
with you.
it's
I'm asking why you're doing it.
it's because usually first degree heart block shouldn't give you syncope, but you might be having a second or third degree heart block in addition to this first degree.
That's true. Could definitely have higher grade block than what you're seeing here. So you want to, shall we say, surveil for that. Is there any other reason that you would do that? And, or I
Uh,
should say, is there anything else you would do? I'm sorry, thinking clearly. Anything else you would do in terms of the evaluation of such a patient?
yes, the etiology of the heart block, like could be like a viral infection, Lyme. What else? Cardiomyopathy, um,
Right.
um, some lupus,
Yeah, lupus
hypothyroidism.
usually it's from the mother, but yes, you
Yeah.
could lupus could. Did you just
Um,
say hypothyroidism?
yes.
Yeah, so you would look at all those things. Is there any utility to doing an echocardiogram in this setting?
Um, I think I would, yeah, I think I would like to exclude that there's a congenital heart disease so that might be causing this.
Well, seems unlikely, right, that somebody at 12 would present with congenital heart disease unless something like an ASD or something. But what other reasons would you do an echo for other than determining whether someone has congenital heart disease? Well, you've already said it, right? Cardiomyopathies, and
Oh, yes.
you could also have myocarditis, right? That could
Right.
cause this. So what about a pacemaker? Is there an indication for a pacemaker here?
Um, I don't think, no, not for a first degree heart block unless there's a higher degree block or it's recurrent for some reason, but not
That's
for,
correct, right. So I have here the official recommendations of the AAP and such. And what you see here is this is for not postoperative patients. So class one, which means basically everybody agrees you should get a pacemaker. So pacemaker implantation indicated in patients with clinically significant ventricular tachycardia that's pause dependent. No, that's not it. Permanent pacing is indicated in symptomatic patients with idiopathic advanced second or third degree block not attributable to a reversible cause. That's not the case. 2A, which is sort of indications where most people would agree with it, but isn't an absolute requirement. Permanent pacemakers reasonable for any degree of AV block that progresses to advanced second or third degree block with exercise in the absence of reversible causes. So, um, you know, it points to why it's important to do the evaluation that you were speaking of in terms of etiology, as well as the Zeo patch or Holter to confirm conduction or to assess conduction. And then a 2B indication would be permanent pacemaker implantation may be considered for patients with intermittent advanced second or third degree AV block not attributable to a reversible cause and associated with minimal symptoms. So essentially, they're saying don't do that. Don't put a pacemaker in there. And importantly, class three, which is nobody would do it. You're wrong to do it. Permanent pacemaker is not indicated for asymptomatic first degree AV block or asymptomatic Mobitz 1. Now, in this case, we do have someone who's symptomatic who has first degree AV block, but we are assuming that most likely the symptom of syncope is unrelated to the first degree block, but it might be. And so that's why it's important to get a good history. And then it's important to remember that if you have neuromuscular disease, the indications are different. And so um, if you have a neuromuscular disease or a progressive cardiac conduction disease, permanent pacemaker implantation is indicated in patients with neuromuscular disease with symptomatic bradycardia due to sinus node disease or any degree of AV block. So if this patient had, for example, as the next line says, Kearns-Sayre syndrome or any degree of AV block, including first degree block, they would recommend a pacemaker because of unpredictable progression, because disease like that has progressive AV block. 2A indications would be permanent pacemaker with myotonic dystrophy type 1 or marked first degree AV block, which would be the case in this patient if that was the case, or intraventricular conduction delay with a QRS, meaning a QRS more than 120 milliseconds. And then finally, last 2A would be permanent pacemakers reasonable in patients with lamin AC gene mutations, including limb girdle or Emery-Dreifuss muscular dystrophies with a PR interval greater than 240 and or left bundle branch block. Defibrillator capability may be considered. So I think a patient like this would require a big workup as you described. Good. Okay. So this is a tracing I saw on Twitter from someone named Sebastian describing a 26-year-old pregnancy at 27 weeks gestation. This is acute onset of palpitations. So the question is, what is the diagnosis and what would you do to treat this? So why don't we ask Dr. Mukapade what she thinks? You still there, Kentucky? Hello? Kentucky, you there?
Sorry, Dr. Paz. I was looking for my app. Sorry, I didn't know I was on. Yeah. So I'm looking at the leads. Looking at lead two. Um, so I see tachycardia appears to be narrow complex, and I don't see a P wave before the QRS complexes. The rate appears to be around five, 1, 2, 3, 4, 5, 6, 7, around 7 small scale, around like around 220, 220, 215, 220.
Mm-hmm.
And it appears to be probably something like an SV, like an AVR, like some kind of an SVT, because I cannot make out a P wave, and the rate is like that.
Mm-hmm. So, what is the differential diagnosis of this?
Um,
You said SVT, but we are cardiologists, so we're no longer pediatricians only. So,
it can be AVRT, AVNRT,
mhm. And those are the most likely
yeah,
too. Um, so, what do you want to do for this patient? 26 years old. She's 27 weeks pregnant.
yeah. So
So
if
you're
we can,
in the emergency room and she's right in front of you.
so since I've diagnosed it as that, so I would probably give her vagal maneuvers and see if that works. But then she's
Yeah.
also pregnant, so I will like give her like do ice on the face, ask her to do Valsalva, and see if that terminates.
Okay, it
If
does
that
not.
if that doesn't happen, then I give her adenosine
Hmm.
to see if that terminates the pregnancy. Sorry, I'm so sorry. If that terminates the tachycardia.
Wow, you
And
want to just really get rid of this pregnancy problem.
sorry.
Okay, so you've terminated the tachycardia. So what do you want to do about this? No.
Um,
So the
so
lady's in sinus rhythm now.
so I'll check back on the telemetry to see if she has had these episodes, if like the like
This
if
is
she
the
had.
emergency room. There's no
Okay.
telemetry.
Um, because I would probably start her on some agent so that she doesn't have it again, just because she's pregnant, and I would probably start her on propranolol and see how she responds to it.
Well, you'd have to really check which agents are okay for a pregnant person and for a fetus. And a lot of beta blockers are actually not great for fetuses. I think probably this patient is far enough into pregnancy, it wouldn't matter at this point, but you could use something like, I think usually the cardiologists prefer something like metoprolol in this setting. But you, the point I'm trying to make here is that you can't just use any agent because some of them are teratogenic, including beta blockers, and some of them are dangerous to pregnancy in general. And so you'd have to basically consult with an adult cardiologist regarding what agents are acceptable. Um, it's interesting. This was posted on Twitter, and a number of cardiologists were commenting on ablating this patient. But I think it would be fair to say that the vast majority of people who were commenting felt it was very dangerous to do an ablation in somebody who's 27 weeks gestation for many, many reasons, not the least of which is um, radiation exposure to a fetus. So, of course, we do ablations now without fluoro, but I think all of us know that at the minimum, there's a potential for the need for fluoro to do an ablation. So, this would be it's just an interesting case because what do you do when someone is pregnant and has it? And this is one of the rationales in my mind when I'm seeing patients in the office who have SVT. Some of you may have been with me when I'm talking to a patient, and I will often comment that although it is not a reason to do an ablation in a child who's, 12, I am more concerned about women and girls who have SVT than I am boys because of our limitations in medicines we can do, as well as interventions that we can do when someone is pregnant. Also, people who are pregnant tend to have more SVT because, well, I'm not entirely sure why that is, except to say that the heart is more swollen, obviously, with a larger blood volume of pregnancy. And so your chances of having SVT are higher, and it's more difficult and less safe to treat it. So I will often say to parents that although it is not a reason to do an ablation when you're, 12, it is probably a reason to consider ablation before your childbearing ages or, in your late teens or early 20s for that reason. Any questions about that? All right. So this is an electrocardiogram obtained on somebody on Twitter. Where is the pathway? So why don't we ask Dr. Kalis what she thinks? Dr. Kalis is on this call twice.
All right. Good morning, Dr. Pass.
Good morning.
All right.
I'm gonna
So,
help you.
all right. Oh, thank you. So, okay. So we're looking at a WPW. So step one says to look in lead one. And in lead one,
This is referring to the delta waves. This is the
yes.
so-called Aruda map, or also sometimes called the Oklahoma map, because Dr. Aruda was working in Oklahoma at that time.
So I don't think the delta wave is, it looks like the delta wave is positive in lead one. So it's not isoelectric or negative. So I'm going to go to lead step two, which is looking at lead two.
Well, did you look at V1 though?
You
didn't finish step one.
Yeah, let me go to the second part then of step one. So, or V1. So R over S greater than 1. So in V1,
is R greater
I would
than
say no, because
That's correct.
V1 is more so negative.
That's right.
So I'm going to then go to step two, looking at lead two. So in lead two, our initial deflection is negative. So that would mean that this is a coronary sinus.
You know what MCV stands for?
Is it the cardiac vein?
Yeah, it's the middle cardiac vein, which comes off of the coronary sinus. It's one of the last drainage points of the CS before the CS enters the right atrium. And so that's right. And actually, if you look at the sensitivity, this finding of a negative delta wave in lead two is probably at the highest sensitivity of all of them and a pretty high specificity as well. So when it's in the coronary sinus or in the middle cardiac vein, it's essentially an epicardial structure. So first of all, so when we see this, this is a good way to get an electrophysiologist agitated because pathways that live in that area of the heart are very difficult to ablate. The reason they're difficult to ablate is because, first of all, it means one needs to be inside the coronary sinus in order to ablate it. So it can be challenging to get the catheter to go into the coronary sinus far enough. That's not an impossibility. Obviously, we put coronary sinus catheters in routinely, but those are smaller. And but in general, we are able to get ablation catheters into the coronary sinus. The other problem is that remember that a normal temperature control catheter, essentially what you're doing is with standard radiofrequency, you're telling the computer, I want you to achieve a certain temperature. Mostly we set it at like 60 degrees Celsius. And I want you to use any power that's necessary to do that. And so the way that ablation works is that if you're in the heart, obviously the blood is moving very rapidly through the heart and is continuously cooling the inside of the heart and cooling the tip of your catheter. So when you're ablating, let's say on the mitral annulus for like a left-sided pathway, if you tell the computer, I want the temperature to be 60 degrees Celsius, it's going to jack up the output until it reaches 60 degrees Celsius. And so what happens is that you have a combination of both power and temperature that are resulting in the electrical delivery and the lesion that you're creating. And it's been shown that you need both. In other words, if you were in an area where there was very little blood flow, then the tip of the catheter would not actually be cooled by the blood. And in the coronary sinus, that's the case. So because the blood flow through a single vein of the heart is not very substantial, there is not very much catheter tip cooling. And so that means that that you will achieve the temperature you want very easily with very little power. In other words, if you're in the coronary sinus and you tell the system, I want the tip of the catheter to be 60 degrees when I'm delivering radiofrequency energy, it might only take 5 watts of energy to do that. But we really need a combination of both temperature and power to create an effective lesion. And so standard RF in the coronary sinus or the middle cardiac vein will almost never result in a good lesion because there's not enough cooling of the tip of the catheter. So as a result, what it means is that the only options are either to use cryo, which does not depend on cooling of the tip of the catheter. And so we've discussed in the past that cryo is great in that it has this feature of little bit of what we would sometimes think of as reversibility, meaning that, if you turn on cryo and you see something you don't like, generally, if you turn off quickly enough, the tissue will not have been completely destroyed and you will have recovery, for example, the AV node. But the downside of the cryocatheter, and one of the many reasons that you don't see Dr. Loveray using it that often, is because it's a very unwieldy catheter. It's a very stiff catheter, and to get a cryocatheter to go into the coronary sinus is very challenging. It's doable, but it is very challenging. And in a smaller child, it's very hard. I've had great difficulty. Once I had to do it from the patient's neck was the only way I could get in. But the advantage of it in that circumstance is that it would be freezing the tissue, which would not depend upon blood flow. But sometimes you can't get that in. And so then the next option is to use the catheter that you've seen Barry use and me to a lesser degree, which is the irrigated catheter, which does not depend on blood flow because you're providing your own irrigation from the system of the tip of the catheter. So you basically are saying, I want the power to be a certain level. And the irrigation sort of makes sure that you achieve that by cooling the tip of the catheter. And it's been shown that that type of ablation makes a much deeper, larger lesion. That's a great advantage in an area like the coronary sinus or the middle cardiac vein. However, these veins are very epicardial. And so if one gets too aggressive with power and irrigation in that area, you can literally perforate the vein and perforate the heart and have pericardial tamponade and a very serious problem. So so it's a catch-22. You want to use something like an irrigated tip catheter, but you want to be careful because if you use too much power, you can literally perforate the heart because of that location. And it can be challenging to navigate or manipulate your catheter in that area to begin with. So if you look at studies of ablation in the coronary sinus, and particularly in the middle cardiac vein, has a lower than usual success rate because of all of these technical issues that I'm describing to you. So although it's nice that the algorithm gets you to the right place, it's the electrophysiologist is hoping that that it's wrong and that it's near this area, but not directly in that area. So any questions about that? Nope. Okay. All righty. This is a 14-year-old female who presents with an episode of palpitations and associated dizziness. What is your interpretation? So why don't we ask, Why don't we ask Dr. Marshall her thoughts on this? This is from the Manual of Medicine, Manual O Medicine.
Well, the manual of medicine handle was obviously taken. All right.
So,
So looking at our EKG here, what stands out to me at first is that we look like we have a widened QRS and a shortened PR. I'm looking at the rhythm stretch, make sure I'm not missing anything at the bottom. So yeah, this looks to me like somebody who has evidence of pre-excitation.
mhm.
In the setting of her having palpitations and dizziness, raises the question if she was having, since she has evidence of pre-excitation, if it was from an arrhythmia or other reasons. In terms of what to do for her, she hasn't seen us before, correct?
That's correct. Where do you think this pathway is located?
So if we look, lead one, we're positive in lead one, so I'd say not there. We're looking at lead two.
Wait, did you check in V1 is R greater than S?
Oh, oops, one sec. I did not. No, it's not.
Okay, so we're now in step 2.
Yep. And then step 2, it is not negative. So
Right, this is
moving,
the opposite of
yeah.
this tracing here.
So moving to step 3, V1, equiphasic or negative. I would say it falls under that as it looks more negative to me.
Mm-hmm.
So then we're looking in septal category. Next, then we would look at AVF. So AVF looks positive to me.
Mm-hmm.
And then we're going to our QRS axis, which is positive. So an anteroseptal pathway.
That's right. So this is an anteroseptal pathway. So what does that mean? Where is it located relative to the compact node and the His?
It's going to be,
Is it close or distant?
I would say closer than like a lateral septal pathway.
Yeah, this is another ECG that the electrophysiologist doesn't love to see.
Yeah.
Because unlike the last one was complicated because of the physical location and the risk for the difficulty of delivering energy there efficiently, as well as the difficulty of the danger of perforation. This one is difficult because of the risk of heart block. So basically then I think it would be fair to say that most electrophysiologists who are seeing this tracing, which has WPW, would assume, rightly or wrongly, that these symptoms are related to the WPW. And so I think most would recommend a formal EP study and attempted ablation. Now, one of the ways that I sort of differ from some electrophysiologists, a lot of people that do this would, if they saw even an 8-year-old, small child, let's say 30 kilos, 25 kilos, they would consider ablating somebody like this. I would generally not, because I would know that based on the pattern of this ECG, the pathway may be close to the AV node in the His-Purkinje system. And so I do use the patterns on these tracings to help guide me. I would rather the patient be a little bit older so that with somatic growth, the distance between structures in the heart as well as the rest of the body will be larger. So 14-year-old girl usually is a well-developed and close to adult size. So I probably would do a 14-year-old girl. I doubt I would ever pass on the patient that age. But if this was a 7-year-old, I personally would wait. I would try to figure out if these palpitations are related to the WPW, and I would wait until the child's a little older. Now, if I documented that the patient was having a lot of recurrent SVT, that would be different. Then I might consider ablating such a patient. But without evidence for tachycardia in a small child with this particular pattern, my personal bias would be to wait in order to enhance the chances that the ablation is successful. Any questions about that? So I would encourage everybody to keep this on your phone, the Aruda map, which is, one of many algorithms, but I think this is a generally good one that at least puts you in the right direction. It's funny, as you can tell, when it's in this area, right, it's very obviously pre-excited because the patient is going down. It's so close to the AV node that the pattern really is largely that of the accessory pathway. If you have a left lateral pathway, oftentimes you are very minimally pre-excited. And there are some cardiologists in the past in my career that I knew that if they were sending me a WPW, it was almost always anteroseptal because they could only tell when it was anteroseptal because they're so pre-excited when that's the case. Anyway, I think with that, we're going to stop. Does anybody have any questions today? Just as an FYI, I'm going away today to a meeting for 4 days. So I'm available by text, but I would just remind that there's a 6-hour time difference. So it's 6 hours ahead in Rome, which is where I'm speaking. So anyway, hope all have a great day and see you at Sign Out shortly.
Thank
Good
you.
luck. Have
Travels.
fun.
Thank you. Thank you very much.